Hello, everyone. Welcome to the Nurses Virtual Workshop in Medically Assisted Reproduction. So today, our session is entitled Treatment at Zone. Where's the evidence and how do we manage patients' expectations? This is a program developed by Medea, Medical Education Academy. I'm Sandra Esteves, and it's my great pleasure to be chairing this session alongside Valerie Petty, that I want to introduce to you. Valerie has worked in fertility nursing for over 30 years and is currently a consultant, midwife, and fertility specialist at Rock Private Health in Aberdeen and honorary research fellow at the University of Aberdeen. Valerie coordinates the ASHRAE Nurses and Midwife Certification Committee and collaborates with the ASRM on developing KPIs for fertility nursing practice. She was a former chair at the Royal College of Nursing, Midwifery and Fertility Nurses Forum for several years. She also served as Scotland's nurse consultant for fertility preservation for several years. She contributed to the development of the Royal College of Nursing Fertility Nursing Education Framework and fertility nurse competencies. So Valerie research focusing on reproductive decision-making and fertility preservation in young people with cancer, and she supports teaching at the University of Aberdeen and Robert Gordon University. She trained in nursing and midwifery in Edinburgh and holds a BA from South Bank University and a Master in Science in Medical Sciences from the University of Aberdeen. So it's a great pleasure to, have Valerie with us. Welcome, Valerie.
Thanks, Sandro. Well, hi, everyone. My name is Valerie Petty, as Sandro's just said, and I will be co-chairing the session together with Sandro today. So obviously, my co-chair is Sandro Esteves, and he is a reproductive urologist specialising in male infertility and assisted reproductive technology. He's the founder and medical director of Androfert, a fertility centre in Campinas in Brazil, primarily dedicated to male reproductive health. He's also a collaborating professor of urology at the University of Campinas in Brazil and an honorary professor of reproductive medicine at Aarhus University in Denmark. He has over 25 years of clinical and academic experience with a vast publication record. He is a world-renowned male infertility expert and serves as associate editor and section editor of many journals, including Human Reproduction, Andrology, International Brazilian Journal of Urology, and Reproductive Biomedicine Online. Sandro has also played a critical role in developing and disseminating the Aphrodite criteria. So welcome, Sandro.
Thank you very much, Valerie. So now I would like to present the official, Medea's introduction. I hope you can see my slides. Okay, so this program, as I said before, was developed by Medea Medical Education Academy. Medea is a global medical education provider. It's dedicated to developing several programs for, doctors, embryologists, nurses. And in the heart of Medea, we have several, areas of interest, including female and male infertility. And each, section of Medea, we have like a scientific committee. Here in the slide, you see the female infertility, which has been established several years ago, having Dr. Robert Fisher as the scientific director and many, key opinion leaders in reproductive medicine participating in this specific committee. So we have also the Male Infertility Committee that was established, subsequently, the Reproductive Biology Scientific Committee, and also the Fertility Nursing and Midwife Scientific Committee. That Valerie is actually a key person in this particular one. So for this program that we are having today, there's an application that has been made to the Royal College of Nursing. So this accreditation, when approved, you get information about that, so you can claim credits in this particular area. The Nurses Virtual Workshop has been accredited by the European Accreditation Council for Continuing Medical Education. So this has been approved and you received credits for that. We want to hear from you at the end of the workshop what kind of changes you making into your clinical practice after participating today. So we ask you to stay for a few minutes at the end of the workshop and complete the survey that we will launch. And then this is important as well to fill a survey that you will receive by email at the end of the workshop. And this survey will allow you to get the certificate that you see in the screen. Today, I will be sharing this session with Valerie Petty. We have faculty, fantastic faculty, by the way. We are having Dr. Yusuf Bibi-John from King's Fertility and King's College Hospital from the UK. We have Professor Joyce Harper from the Institute for Women's Health, University College London, and we have Marina Viana from our center, Androfert in Campinas, Brazil. So here you see, the faculty disclosures that they will also highlight during the presentations. And this program has been developed in partnership with many, groups, including Group Poseidon, Group Aphrodite, and in partnership with several societies from different countries and regions. So we are very glad to have the support from all these important institutions. So this program, we have approximately 400 participants. Thank you very much for all of you to register and attend the sessions. And participants are coming from approximately 40 countries. The agenda that you see in the screen is a program of about 2.5 hours. And then we will have 4, key presentations. We have in the first session, one talk about endometrial receptivity, followed by pre-implantation PGTA. And then after the 2 presentations, we'll have a Q&A session. And after that, we have session 2, in which we will be exploring the good practice recommendations on add-on and then supplements for female and male patients, and then followed again by Q&A, and then we conclude the presentation. So we'll invite you to participate actively during this webinar. So for doing that, please submit your questions. We have the Q&A, box that we will try to answer the questions live, or we will type answers in the Q&A if not possible to answer all questions live. But please use the Q&A box to post your questions during the webinar. So the other thing that I would like you is actually the questions will be at the end of the session. So please, prepare your questions and start posting the Q&A. So with that, I would like to ask Valerie to give the lecture Endometrial Receptivity and Key Components of Immunology in Fertility Treatment. So Valerie, the floor is yours.
Thank you. I think I've got control of the mouse. I'll just double check. So my grateful thanks to the Medical Education Academy for facilitating this free webinar with a focus on treatment add-ons and our duty of care in ensuring that our patients receive impartial, evidence-based information from which to make informed choices and decisions regarding their fertility journey. And my session today will focus on endometrial receptivity in this regard. And these are my disclosures. So the mechanisms underlying human endometrial receptivity, as we know, are complex and not well understood. Yet investigations and procedures have emerged that investigate endometrial receptivity and classify the endometrium as being either pre-receptive, receptive, or proliferative. Therefore, the purpose of my session is to highlight the excellent resources that guide evidence-based fertility care in this regard, in addition to discussion of the commonly applied treatment add-ons, including their efficacy, their safety, and the available evidence. And finally, I'll discuss our duty of care as fertility nurses and midwives when consulting with patients considering or requesting treatment add-ons. So this slide represents an extract from the ESHRE Good Practice Guideline on Treatment Add-ons and provides an overview of the 4 standard phrases that were used for the formulation of the recommendations and their implications. Where an investigation or treatment has robust evidence, it can be applied and adopted as policy in most situations, and an example of this being ICSI. Where an intervention has some evidence of benefit, for example, in a specific patient group, it may be considered after thorough discussion of the risks and benefits with close monitoring and full evaluation. But where there's limited evidence for implementation of an intervention or treatment, it would fit the criteria as not currently recommended for routine clinical use. And finally, where safety concerns exist, the intervention or treatment add-on would not be recommended or considered only within a strict research setting. In response to the emerging implementation of treatment add-ons, the Human Fertilisation and Embryology Authority, or the HFEA in the UK, introduced a traffic light rating system for treatment add-ons in 2019 to support informed choice and patient decision-making. In 2023, the authority implemented a 5-colour rating system that indicates whether evidence from studies show that an add-on is effective at improving treatment outcomes. And in essence, the HFEA grading system complements that of ESHRE's Good Practice Guideline, with both publications informing this presentation. Despite improvements in IVF technology over time, pregnancy rates have generally plateaued, with high-quality euploid embryos often failing to implant. And as a result, many patients are faced with the diagnosis of recurrent implantation failure after repeated unsuccessful embryo transfers. These observations have led to an increased focus on the role of the endometrium in implantation, and several add-ons have appeared on the market with the promise that they will improve the receptivity of the endometrium and increase the probability of live birth. However, as we know, successful implantation requires synchrony between the endometrium and the blastocyst. And a good blood supply to the endometrium has also an essential requirement for successful implantation, with assessment of endometrial blood flow now attracting a lot of attention in recent years, and which will be discussed later in this presentation. Ultrasound has been used commonly to assess endometrial receptivity and provides an easy and effective method of measuring endometrial thickness. According to several frozen replacement cycle studies, if the endometrium is less than 7 millimeters, this has been associated with a significantly decreased likelihood of pregnancy. The available evidence also suggests the morphological appearance, this being the trilaminar or triple layer appearance, is also a significant independent predictor of implantation, with some studies reporting a 3-fold increase in clinical pregnancy rate in frozen replacement cycles. Therefore, endometrial pattern, in addition to thickness, should be considered prior to the transfer of cryopreserved embryos. And in fresh cycles, there is correlation between endometrial thickness measured on the day of ovulatory trigger and clinical outcome in normal responders with GnRH antagonist protocols. The aim, therefore, is to summarise the available evidence for common IVF add-ons which suggest their ability to enhance endometrial receptivity. So demand for medically assisted reproduction, or MAR, as ESHRE like to call it now, is increasing globally, in part due to the continued worldwide decline in female and male infertility and advancing female age at first pregnancy. And we know that female age will override any research and evidence that we currently have. Whilst advances in medically assisted reproduction have created scope and diversity in treatment options, novel processes, both evidence and non-evidence-based care, have also increased patient expectation. Processes or treatment add-ons in relation to endometrial receptivity lacking robust evidence include immune therapies and invasive procedures which aim to enhance pregnancy chances and live birth rates in addition to reducing the risk of miscarriage. It's therefore essential that we understand the clinical and physiological rationale for treatment add-ons, including their attended effects, their risks, and their side effects. If we go back to ultrasound examination of the endometrium, as we know, it's commonly used and it's a non-invasive method to assess endometrial receptivity during IVF treatment. A good blood supply towards the endometrium is usually considered to be an essential requirement for implantation, and therefore assessment of uterine and endometrial perfusion again is attracting a lot of attention. However, it's important to note that Doppler study of uterine arteries does not reflect the actual blood flow to the endometrium. Endometrial and subendometrial blood flows can be objectively and reliably measured with 3D powered Doppler ultrasound. However, conflicting results are reported with regards to their role in the prediction of pregnancy and fertility treatments. Relevant studies differed in patient characteristics, the day of ultrasound examination, and the selection of the subendometrial region, and that being due to inter-operator variability. In addition, the degree of change in endometrial perfusion from the late follicular phase to the early luteal phase may be a more important determinant of endometrial receptivity. The European Society of Human Reproduction and Embryology recognises the role of uterine artery Doppler in assessing endometrial vascularity, but current research indicates that there is no consensus on standalone value for predicting pregnancy outcomes. Endometrial receptivity is a complex process, and multiple factors are generally considered more reliable than a single ultrasound marker. So endometrial scratching is the next one that I want to focus on, and it's also termed endometrial injury. And it's implemented in the luteal phase of the menstrual cycle, usually in the month before planned fresh or frozen treatment, and has been proposed to improve the chance of implantation. Although debated and unsupported by evidence, the hypothesis is based on the potential of induction of endometrial deciddualization and triggering of a wound healing response associated with a beneficial inflammatory response. Thereafter, the modulation of gene expression involved in the preparation of the endometrium and improved synchronicity between the two by retardation of endometrial maturation results in asynchrony. Numerous studies and systematic reviews have been published on endometrial scratching, with the most common Cochrane systematic review and meta-analysis, which included a total of 37 RCTs and almost 9,000 participants, concluded that endometrial scratching probably results in little or no benefit in risk of miscarriage. Therefore, while some studies have shown marginal benefit, others have not. And therefore, on balance, there is no clear rationale for endometrial scratching or endometrial receptivity array, currently rated amber by the HFEA. With regards to immune therapy and intralipids, there may be clinical justification for implementation of intralipids. Therefore, this slide doesn't relate to women with pre-existing autoimmune conditions, including thyroid disease and antiphospholipid antibody syndrome, or to women prescribed immune therapies such as steroids for other medical reasons. However, in reproductive medicine, there's an increasing interest, yet controversy regarding the benefits of intravenous intralipid therapy as an adjunct or add-on therapy in selected patients with a history of recurrent pregnancy loss or recurrent implantation failure, where immune issues are suspected but not proven. The proposed value lies in its potential to modulate the maternal immune response and improve the implantation potential of the embryo. Endometrial biopsies to assess the number of natural killer cells are difficult to interpret because cell numbers increase rapidly during the secretory phase after ovulation, and this is thought to be in response to progesterone levels rather than having a causative role, and as such, likely to differ month on month. How numbers might relate to their functions is also unclear, as it's still unknown exactly what uterine natural killer cells do in normal and abnormal pregnancies. And it's frequently reported that there's no evidence to support the effectiveness, utility, or safety of this treatment due to the lack of clear biological rationale or clinical relevance for blood tests assessing various immune parameters and uncertainty regarding their selection and interpretation. For uterine natural killer cells, there's general ambiguity regarding their role in endometrial function and implantation, and no consensus on reliable normal reference ranges, as the local uterine immune populations are vastly different from those found in blood. Therefore, there is no clear rationale for intralipid therapy currently rated red by the HFEA. So what about corticosteroids? Well, we know that prednisolone is a corticosteroid prescribed therapeutically for the treatment of autoimmune conditions such as systemic lupus, erythematosus, and rheumatoid arthritis, and therefore in these cases not considered a treatment add-on. Glucocorticoids mimic the body's natural cortisol hormone to reduce inflammation and suppress the immune system, and when implemented without clinical justification, are thought to improve folliculogenesis and clinical pregnancy rates. However, the data is again inconsistent. Glucocorticoids have also been examined in patients considered to have an immunological factor preventing pregnancy and/or live birth. However, a Cochrane review reported that the live birth rate and clinical pregnancy rates were comparable across groups assigned to either glucocorticoids or placebo. Several other studies, including a meta-analysis, showed no benefit. Whilst the data is limited with regards to the safety, an increased risk of miscarriage, preterm births, gestational hypertension, and diabetes have been reported. Therefore, there is no clear rationale for corticosteroid therapy currently rated red by the HFEA. What about intrauterine HCG? Well, human chorionic gonadotrophin, or HCG as it is more commonly known, is a hormone produced during pregnancy and believed to regulate embryo implantation. In fresh IVF cycles, it's also administered to induce final oocyte maturation in normal or predicted poor responders. In the context of treatment add-ons, intrauterine HCG is administered as an implant-enhancing agent directly before embryo transfer, the preparation being powder form reconstituted with either sterile water or saline. Administering a low dose of HCG directly into the uterus is thought to improve implantation by preparing the endometrium to be more receptive and supporting immune cells involved in the implantation process. However, the exact timing, dose, and patient selection are areas of ongoing research to determine its consistent clinical benefit. In addition, intrauterine infusion of HCG has been shown to upregulate cytokines known to be involved with implantation, with injection of HCG directly into the uterine cavity prior to embryo transfer, suggested to increase the probability of successful implantation by ensuring sufficient levels of HCG are present. However, another Cochrane review identified 7 RCTs, and the authors observed inconsistency between trials and therefore unable to obtain meaningful data. Whilst a small subgroup analysis suggested an increased probability in pregnancy of women receiving an HCG dose of greater than 500 IUs prior to cleavage stage embryo transfer, so you can see how old this study is, this finding was not considered meaningful. And therefore, the HFEA has rated intrauterine HCG as grey, suggesting that it is insufficient of moderate to high quality evidence to determine whether it's effective at improving the chance of pregnancy and fertility treatments. With some broadcasting authorities and newspapers highlighting the pitfalls of fertility treatment add-ons, the media and social media significantly influence the perception by promoting unproven treatments, leveraging patient hope, creating peer pressure, and often providing incomplete or misleading information, and selling hope to vulnerable individuals desperate to increase their chances of pregnancy. This narrative can create a belief that those add-ons are necessary for a successful outcome, even in the absence of robust data. Fertility clinic websites often list add-ons without clearly stating that their effectiveness is unproven and fail to state that they're not part of standard treatment, incurring significant cost. In a paper published in BMJ Open, researchers looked at claims of benefit for interventions offered by fertility centres in the UK via the information contained on the centres' websites. Then they looked at what evidence was cited for these claims. They report that while many fertility centres in the UK offer a range of IVF add-on procedures and prove claims of benefit for many of these interventions, in most cases the claims are not quantified and evidence is not cited to support them. Social media platforms provide a strong community and support network for individuals with infertility, and they often use them to supplement information they receive from healthcare providers and gain insight from others' experiences, which can lead to pressure and pursuing add-ons. Nevertheless, while social media offers support, it can also induce anxiety and fear of missing out on potential benefits, pushing patients to try any available option to avoid mitigating long-term regret. Therefore, despite the substantial cost, add-ons can double the price of an IVF treatment cycle, with patients often reporting a lack of complete cost and effectiveness information before starting treatment. Media attention has highlighted these transparency issues, encouraging regulatory action and better communication from clinics. And what about our duty of care as fertility nurses and midwives? And I am aware there's probably scientists and doctors joined this session as well. So I think we all have that duty of care. So the growth of use of add-ons, especially in the UK, is the result of several factors. The UK fertility sector is an intensely competitive market, unusually for healthcare in this country, with approximately 60% of treatments are privately funded. With most and some NHS clinics, that's the government-funded clinics, treating a mix of privately and publicly funded patients. Since information about add-ons is increasingly available online, many patients have strong views about their apparent advantages of a particular treatment add-on before they even step into the clinic. This combination of patient expectation, market forces, and realignment of the professional-patient relationship in an online information age appears to be driving supply and demand for treatment add-ons. Fertility nurses and midwives have a duty of care to ensure fully informed decision-making while separating commercial interests from best practice advice. And we believe that culture change is required if the potential benefits of new treatments are to be offered responsibly, whilst implementing best practice as advocated by the HFEA and ESHRE guidance. And so in conclusion, this presentation has summarised the current evidence for common IVF add-ons, suggesting to improve endometrial receptivity. The results suggest there is no robust evidence that these add-ons are effective or safe. Our duty of care as fertility nurses and midwives is to provide clear, impartial and evidence-based information about the effectiveness and potential risks of all treatments, allowing patients to make genuinely informed decisions. And finally, there is a need for greater regulatory oversight and implementation of the excellent guidance published by ESHRE and the HFEA in this regard. Thank you.
Thank you very much, Valerie, for this excellent and very comprehensive talk about endometrial receptivity at ZON. I want to remember the participants that we will have the full version of this and other lectures available on the e-learning platform. And you can start posting your questions in the Q&A session during the talks. So you can go ahead and do that. But now it's my great pleasure to introduce Dr. Yusuf Bibijan. Dr. Yusuf, he's a PhD candidate and consultant in reproductive medicine at King's Fertility and King's College Hospital in the UK. He completed his medical degree at King's College London, followed by specialty training in OBGYN across Guy's, King's, and St. Thomas NIH Foundation Trust. He was also a fellow in reproductive medicine at King's Fertility. So he has a brilliant CV. He was a clinical scholar at Harvard Medical School, holding a master's in healthcare delivery and leadership from Mount Sinai Hospital in New York. He has, interest very much into pre-implantation genetic testing. So I believe he's the best person we could, and we are very lucky to have him presenting this, presentation on pre-implantation genetic testing for aneuploidy, because he has presenting this topic in major international conferences, and he's also contributing to a fantastic ongoing study on the matter concerned, and that he's going to cover during this presentation. So Dr. Yusuf contributes to medical education at King's College London and also at Harvard Medical School, and he currently serves as secretary of the OBGYN section at the Royal Society of Medicine. So welcome, Yusuf. We are very happy to have you here with us today.
All right, thank you so much, Professor Estes, for this really good introduction that you've kind of set the scene now. So thank you everyone for joining us today as well. So it's my great pleasure to talk to you about the most controversial topic in IVF, PGT. So bring on the questions and hopefully it'll be an interactive one. So I don't have much conflicts of interest, but I will be talking a little bit in terms of the PGT trial that we ran at King's. So that's my major conflicts. Otherwise, there's nothing here that's relevant to this talk as such. So when we look at PGT, one of the main things we need to look at is actually why is that relevant? It's relevant because from a fertility point of view, we've known that for a while, that when someone wants to achieve a pregnancy, it doesn't always match when they can. And that's known as this age versus tempo versus quantum conundrum. So the best age to have a pregnancy doesn't really match when you want it. And when you do want it, you actually can't have it for various reasons. And when you look at the human fertility curve as such, you see that it's a bell-shaped curve where you have difficulty conceiving towards the early years, and then later half of the reproductive years. And this bell-shaped curve is something that we see quite often, and it's quite relevant from a fertility point of view, because the patients that we see, or that's relevant to us, are the later half of that curve. Whereas now, in terms of when we try to understand why this curve is such, we realize that evidence has been gathering over the last few years. And the concept of aneuploidy came into play when they started detecting that there's an element of embryo aneuploidy being seen with various women, and then they span it out and they figure out that there may be a maternal age associated with that. And this is relevant in terms of the various publications that came in where they started seeing certain aneuploidy, certain trisomy, for example, Down syndrome being associated with maternal age and paternal age. And then the aneuploidy spectrum grew bigger and bigger. And what we see at the moment is we go back to that bell-shaped curve. What we understand is towards the early half of reproductive years, there's an element of biological immaturity that drives reproductive rates down, whereas towards the second half of the bell-shaped curve, you have a rise in meiotic chromosomal errors. And we'll just go in a little bit more details about this so you can appreciate the reasoning for PGTA to come into play. So why is meiotic error, why is it? What's the problem with it? And we know that females are born with a finite number of eggs. Those are known as oocytes. They enter, if you go back to your basic science now, they enter meiosis 1, and then they are rested there until ovulation. Ovulation can happen at the age of 18, or it can happen at the age of 40. And the time frame between egg being ready and eggs coming out is known as decade, can be decades, right? To go through. And the genetic component of the egg is actually stabilized by something known as chromatins. There's a spindle that goes through. And as the older you get, those chromatins become very unstable. And it's this dissociation effect of the genetic component that then leads to egg aneuploidy as such, which then translates to embryo aneuploidy. And what do we see as evidence is being gathered? You see that as maternal age or reproductive age, as we call it now, goes up, you have an incidence in embryo aneuploidy as well. We go into a bit more details about this in terms of what actually do we mean by aneuploidy, what kind of chromosomes are there, is it specific chromosome, is it all of it? And there's a really nice paper by Professor Capalbo who sees that actually it's an overall rise of pretty much all chromosomes that goes up, and that's what drives the concept of genetic abnormality. What that means for our patients is as they get older, which we're all seeing patients getting older and older, they need a higher number of eggs in order to achieve an embryo. And then if you're looking at an embryo that can be biopsied, it's increasing with number of age. Increasing age requires higher number of embryos being able to be biopsied or biopsiable quality. And then if you have something that's biopsied, whether it's normal or not, it's a different story. And you have these tendencies, all the same graph, right? As age progresses, numbers needed goes up and up and up. And if we look in terms of what we know, we all know that with advanced reproductive age, live birth rate goes down. And with that comes miscarriage rate that goes up. And the concept is that extension of that is aneuploidy goes up as well. And this is why PGT has been suggested to potentially be a better way to identify an embryo. So how do we select an embryo? There are different ways that your clinics may be doing, but the most common one that we do is the Gardner classification. So this is a pictorial representation of the blastocysts, who we all have seen before. And the grading is usually based on how good looking the embryo is, how expanded the embryo is, and how the cells are aligned. You grade the cells, the trophectoderm, which forms the placenta on the outside, and then you grade the cells on the inside, and you see, oh, it's an A, B, a C, and that's known as morphological assessment. So in terms of how beautiful an embryo is, and that could be relevant in terms of how likelihood that embryo is to lead to an implantation and then lead to a clinical pregnancy. But what we do know, and there are some limitations to morphological grading, is that it's quite subjective. So it's subjective to two things: subjective to the person grading it, and subjective to the time at which this has been graded. So there's an element of it's not very objective. So we know that two embryologists sometimes, very often, grade the same embryo differently. So a 4BB for someone could be 4AB, could be something else. So there's not a very objective way to grade it. There's an element of subjectivity and timing to it. And also there's a disconnect in terms of how something appears and what's actually happening inside. And that's where the genetic component comes into play. So you have contradictory outcome, and we've had situation where you may be aware from a nursing team where a 5AA was transferred and it doesn't lead to anything. If something of a poor morphology as such was transferred, and that leads to clinical pregnancy. There's a disparity here in terms of what something looks like and what actually it contains. And it also has an inability to detect the errors going in it. So this is why the concept of PGT comes into play. So can we go beyond morphology? Morphology is good, but can we go ahead beyond it? And this is what PGT comes into play. PGT-A, this is currently known, test for aneuploidy. It's a screening tool, and that's important for you to appreciate. It's a screening tool. And the reason why I say it's a screening, because it depends how relevant it is for the patient to do. Not every single patient needs to just go ahead and have a PGT on the embryo, and we're just going to go through that in a moment. The goal of PGT is to select from a pool of embryo, potentially, which one is genetically normal, which is known as euploid, and which one is abnormal, which is known as aneuploid. So, so this is what PGT comes into it as a way to rank the embryo that you have. Testing is usually done on day 5 to 6 at the moment, which then, well, which I'll go through the different types of PGT over the last few years. And usually around 5 to 8 cells are taken from the trophectoderm of the biopsy, so we leave the inner cell mass as such undamaged. So the proposed advantage of PGT is that it will identify an embryo that looks good, but is also genetically normal as well. And by default, this will then have the highest likelihood of an implantation. And by being genetically normal, you will have lower miscarriage. And by transferring a euploid genetically normal embryo, you will shorten the time to pregnancy for these patients. So instead of transferring embryo after embryo, you'll just bring forward the euploid transfer. And going a bit beyond that, it will promote the concept of a single embryo transfer. So you don't need to transfer multiple embryos in, just transfer the one that has the highest likelihood of working. And by promoting a single embryo transfer pathway, you would reduce the maternal and neonatal risk associated with multiple transfers. So, so PGT as a concept is not new. It's been around for years. And if you look at PGT being done in the 90s, they were only testing 8 chromosomes on day 3. Issue with that, it's low specificity, high positive, high negative, false positive, false negative. It's quite challenging to just take a few cells from 8 on day 3. Moving on to the 2000, we moved on to RACGH, which allows us to assess all 23 chromosomes. This is blastocyst stage biopsy now, so we're moving on from a day 3 to a day 5, and allows us to detect whole chromosome. Moving on further, mid-2000s, we went on to next generation sequencing, which is what's most commonly practiced at the moment. This allows millions of fragments to be on. It's digitalized, quantified, it's mapping, it's digital read counts, and allows its lower rate of errors with that. So at the moment, what's recommended is PGT via next generation sequencing. So obviously, as an intervention, this has been looked at by various collaborators where they've thought about randomized controlled trial being performed in terms of PGT. Some papers say it works, some papers say it doesn't work. But the issue with PGT, if you look into it in terms of why is there such controversy with PGT? And we go back to the first slide that we've done about this bell-shaped curve here, where aneuploidy, as we've realized and we've understood by now, affects the later half of the reproductive age. It doesn't affect someone who's 19 or 20, or actually 19, 20 is relevant, but someone around the age of 27 also. And this is why we go into this arena where is the evidence for PGT flawed, which then becomes this whole controversy that people love arguing. Every ESHRE, ASRAM, you find people arguing about the same thing, about how good is the evidence for PGT. So looking at all the RCTs that's been done in PGT, we've established that we need to do it on a day 5, because on a day 3, you'll have false positives. So how many of them are blastocysts? Not many. And we've established that aneuploidy is something that affects advanced reproductive age. So it needs to be above a certain age. How you define advanced reproductive age is another story, but let's assume it's above 35. What you will see is a disparity here. There's no study that looks at aneuploidy, PGT, as a relevant intervention tool at blastocyst stage for women above the age of 35. So this is why the argument carries on and on and on. And if you're looking at how guidelines are being written, for example, like Barry has said, from an ESHRE guideline point of view, whether it's an ARSRM committee opinion, whether it's the HFEA add-on, whether it's a NICE guideline in the UK, they rely on grade A evidence. Grade A evidence are based on RCTs. Because there are no RCTs, that's actually looking at the concept of PGT for the right population demographic is therefore not recommended because there's nothing that's been proven in that specific age group. And rightly so, guidelines has to adopt a routine stance, which is not recommended for everyone. But what it can be considered for is potentially for women at advanced reproductive age. For ESHRE, HFEA says for it's a miscarriage reduction strategy on their add-ons. And it can be done for those particular patients, which I'll go through in a moment. So, so when we look at PGT in terms of the evidence, people still carry on arguing, right? Even with all these things, you have patients say actually it's a waste of time, and then you have people who say actually probably still does work, and then you have the whole concept of actually the RCT was never designed properly anyway. So it doesn't matter whether you have the right age bracket or the right testing, is just not been designed, the statistical is not done. So the argument, as we know, you have patients say there's no evidence for PGT, and then you have the other side of the argument say actually our RCT was small, the design was not great. Then we have patients say, oh, actually you're throwing away good embryos, and then the other side, people say actually you don't know what a good embryo is because people did argue anyway. PGT is not accurate, and then the counter argument is morphology is not objective anyway. It does not improve cumulative live birth rate, is an argument that we always hear. It was never designed to improve cumulative live birth rate. And the argument says it should not be offered to everyone. Yeah, you're right, aneuploidy does not affect everyone. So where do we stand? We stand in terms of there's a need to potentially have a trial that looks at PGT for advanced reproductive age as such. And this is where we come in at King's. We started designing what would be the feasibility of doing a trial for advanced reproductive age. We published our pilot, our study protocol for our pilot study 2 years ago. And this year we've just published the results of our pilot RCT, which I'll just go through that at the moment. It's important for us to appreciate that the results here have not been powered, but they give us potentially a trend in terms of what we may see if we do a full-on trial. So this was a feasibility study. And the bottom line is it's feasible to do a PGT trial for women of advanced reproductive age. From a clinical point of view, clinical outcomes point of view, like I said, it's not been powered. There was no difference in clinical pregnancy, live birth, or miscarriage at first transfer. But when you look at a cumulative live birth rate over a 1-year period after 3 embryo transfers, that's when you start seeing a potential benefit of PGT. What we mean by that is looking at the time to live birth. What we see is for women above the age of 35, the use of euplod embryo will bring forward the chances of a pregnancy earlier. And the live birth probability of an embryo for each sequential embryo transfer, euploid has a higher likelihood of achieving that pregnancy sequentially. And like I said, we don't know what advanced reproductive age is. Is it 35? Is it 38? And the graph on the right shows the time to live birth difference for above 35. And the graph on the left for above 38, you can see higher demarcation, which means that potentially identifying a euploid embryo in someone above the age of 35 and definitely above the age of 38 will shorten that time to live birth. So this is where we are from a PGT trial point of view. The next step is, as Prof. Sanders has mentioned, we're currently designing the full-on trial, which will be a multi-center trial, which will be run through King's. So what are the potential indications for PGT at the moment? It could be considered for patients above the age of 35 to 38. This is the advanced reproductive age. Could be considered for patients with recurrent miscarriages. Again, a lot of the time miscarriages happen and we don't have the cytogenetics for the products of conception. So if you think there could be an element of aneuploidy there, so it could be relevant for that. It's relevant for patients who have multiple aneuploidy confirmed, or more importantly, in situation where they have a number of embryos, is there as an embryo selection strategy. And if there's some male factors, sometimes PGT is indicated as well. So how does it look from a PGT pathway point of view? From a nursing point of view, you will have your patients who will have their ovarian stimulation, then they have their egg collection, and then at egg collection, the eggs are fertilized, and then you'll have a blastocyst culture to day 5. At that point, you'll have a trophectoderm biopsy performed on day 5, and then it will send to lab to be analyzed by NGS. At that point, all your embryos are frozen, and then we wait for the results, and then you can have an embryo transfer. So how does a biopsy work? So, so the way it works is, what we see here is an example of a blastocyst, and you will see that the embryologist of biopsies is identifying the area of trophectoderm that will be biopsied, and around 5 to 8 cells are then taken out from the trophectoderm biopsy, from the trophectoderm level, and then that's sent to the lab to be analyzed, as you can see here. And obviously there's a risk of trauma when you do this with an embryo, so that from a counseling point of view, it's important for patients to be counseled appropriately. So results will come back depending on the platform that you use. You'll have embryos that are being regarded as completely euploid, that means has the correct number of embryos completely, aneuploid, not correct number of chromosomes, and you have this whole concept of mosaicism, which it's a whole lecture on its own, but basically you have a mix of normal and abnormal. And it's important for us to liaise with the genetics team as well, so that the patients can be appropriately counseled. So it's important to know that a PGT does not improve the embryo in any way. It just potentially helps us choose the most promising embryo that could lead to improving clinical pregnancy. Different chromosomes have different issues. I've just listed it here. All monosomies are lethal, so they will not lead to clinical pregnancy. Trisomies are abnormal, but some are compatible with life. For example, Down syndrome being an example of that. And then you have the extra sex chromosomes, which will be identified as well. So what you need to know from a nursing point of view for mosaicism is that not all the cells are universally abnormal or normal. They can lead to a clinical pregnancy, but they have lower implantation rates and a higher miscarriage risk as well. The definition of mosaicism varies from your platform that you use for your genetic testing. So it's important for you to realize which platform you're using and how they're defining mosaicism. As such, it's important to link that up with the genetic counseling so that they can get the proper counseling. And you would not transfer mosaic embryo as first choice, but if you don't have no euploid, then you could consider transferring a mosaic embryo. And I know some genetic platform now are redefining low mosaic and high mosaic as euploid and aneuploid anyway. So we may go back to just a very binary result. Limitations of PGT is that it does not guarantee pregnancy. It does not increase the total number of embryos that you have. Misdiagnosis is rare at this point, and there is an element of trauma, like I said, so embryo may not survive the thawing and freezing process. From a nursing counseling point of view, it's important to have this. And also, patients to be counseled that they may have no normal embryos. So that's important for them to understand that from the outset, that could be the case. And obviously, there's no fresh transfer. So it's a freeze-all strategy, which then delays the treatment or defers the treatment in a way. So the nurses' roles in the PGT, actually you guys will be doing stuff that we don't do very well, which is spending a lot of time with our patients. So in terms of talking to them, what it involves, educating them in plain language, what PGT actually means, making sure the consent is in place and they actually know what they're signing up for, coordinating the PGT journey for the patients, communicating with the lab and waiting for the results and providing support that's needed, and linking from a clinician to patient point of view. How you prepare your patients with PGT varies from clinic to clinic, but the important thing, and what I see from my practice, is actually explaining the timeline appropriately, defining a clear indication for it, and setting expectations, like we said, that not all embryos will reach blastocysts, so you're actually committing to a freeze-all. And if you do have embryos or biopsies, you may not have anything available for transfer. They're all abnormal in a way, and providing the emotional support and the realistic counseling associated with that. And you will find out from a nursing point of view again that patients need the support required, because they'll be shocked, and they will have an element of guilt or self-blame in terms of, I've delayed this pregnancy, I've delayed conception, it's my fault. So it's actually quite the other human factor associated with it, that as doctors we don't do well, but as nurses you guys do much better than us. And it's the loss of control that they have on the results. It's literally a waiting game to see whether after 10 days of stimulation and biopsy, has it all been worthwhile? And if you have one euploid that's available, do we transfer, do we optimize, do we go for more generation, etc. So it's important for you as nurses to just be there to link everything up. I'm just going to touch briefly on non-invasive PGT, which is just, I just want to put that on there because this is being very debatable and there's quite a lot of media attention around it. The concept of non-invasive PGT is like, instead of taking a biopsy of the embryo, how about we find a pseudomarker to assess the genetic component of the embryo, whether we take some fluid from the blastocyst or we look at what's happening in the media around the blastocyst. And this has led to class action. You would have read it in the news as well. So where we stand at the moment, the accuracy of non-invasive is still under evaluation. So it's not something I'll be promoting at this point in time. So also briefly, the last few slides here is just looking at, cost effectiveness of PGT, something that sometimes as clinicians we just say, oh, just go ahead and do it. But it actually has a cost implication on patients as well. And we sometimes take it for granted that, oh, they'll just pay for it. But it's actually, it may not be worthwhile. In addition to the clinical outcomes being debatable, it also has a massive financial cost on the patient. We say that above a certain age it may be useful, but will they get enough embryos for it to be useful? The more embryos you have, the more relevant it is, but the costlier it gets. And there's this analysis by this paper in FNS by Eleanor, which shows that, regardless of age, you will have a balance where PGT will actually outdo the financial benefit associated with it, because you're paying per embryo here. And usually the cutoff is between like 6 embryos. Afterwards, the cost becomes too much for patients to have a financial benefit out of it. This is my last slide here, just to let you know that there are resources out there for which I've used for this presentation. There's great guidance from the HFTA website, which looks at how they graded the add-ons. You do have PGT statements from ASRM and ESHRE, which is worth using. Your clinics will have information leaflet, and your National Health Service will have it as well. The genetic team is the best person I work with. They know more about genetics than I do. And they'll be able to tell us exactly the relevance of aneuploidy, the relevance of the mosaicism, whether it's worth transferring. And there's quite a lot of patient support groups as well that patients can get in touch with. We have one within our clinic for the aneuploidy status to see how they can talk about in terms of whether there's a need for a second cycle as such. And so that's it. So thank you so much. So I'm happy to have any more questions in the break if you have any. So thank you so much.
Thank you very much, Yusuf, for this fantastic presentation. The pilot study is very, exciting to see these results, and I'm sure we will have some questions here to explore it in more detail. Thanks a lot. Yeah, I would like also to ask Valerie to join us, because now we are opening, the Q&A session for session 1 of this webinar. So thank you both for joining now the discussion. I would like to start with Valerie in terms of, could you, Valerie, get back again to the colors, the classification, because in your presentation, you were stressing that amber was only available for, endometrial scratching. And for, the rest of interventions, I see that there's either, no indication because of concerns of safety, or we don't have enough moderate high quality data to, you know, support an intervention. But for scratching is a bit like, you know, the amber. So could you explain to all of us what amber means and how you actually counsel your patients these days about when they come with, you know, especially implantation failure from other centers, and they are asking you about scratching?
So I think we have to just be very honest that the data shows no benefit, but equally shows no harm. So I think that's where the amber rating comes in. So I am of the opinion that as long as a patient fully understands the rationale, the safety, the efficacy, and the results of the published studies, and I mean the numbers are large enough, I have no problem consenting a patient to endometrial scratch as long as they are aware of that. So does that answer your question? So equally, it does no harm, but equally we know that there's no clear benefit. And I know there's a small sample group of women who have benefited from endometrial scratch, but again, whether that is coincidental and would have happened without endometrial scratch, again, I mean, they say all research is flawed. I mean, we know that. But I think we just have to go with the available evidence, the current guidance, and obviously the HFE rating system and ESHRE good practice guideline, and they do complement each other. And I think that's the best we have so far. I see Joyce is nodding, so I hope she's agreeing with me.
Yeah, I would like also to, you know, welcome Professor Harper. She's joining us for the discussion. She's going to be properly introduced after we finish, you know, this, you know, discussion before her talk. But I would like to welcome you to our webinar, and thank you for joining the discussion part, and feel free to add, you know, your views on, you know, the adds-on on endometrial receptivity as well. I know you cover part of it during our presentation, but yeah, you are mostly welcome to express your views as well.
Thank you, Sandra. I will obviously talk a bit more in my talk, but I want everyone to be able to ask their questions, so I don't want to take up their time because their questions are more important than mine. But just to say, I will say now with Youssef, we have a very different opinion. I was involved with setting up the ESHRE ESTEEM study, and it was for advanced maternal age. The oldest age was 40, and the STAR trial, the upper age was also 40. They were advanced maternal ages. And as you say, the trouble with doing this in women over 40 is that we get very few embryos. But yeah, I think we have 30 years of clinical studies now on PGTA, and I'll explain more about that in my talk. But yeah, just to let people know that people have different views, and as you said, we've argued about this for a long time, and I've said the same thing for 30 years, that we need clinical evidence, and we've got 30 years of clinical evidence, and it doesn't work. So but because what clinics are doing is they're saying to the patients that it's going to improve your chance of a live birth, and there are various reasons why that wouldn't happen with advanced maternal age from what we've seen. But I'll let everyone else ask their questions.
Can I just add as well, again, when it comes back to fully informed consent, I moved from government-funded hospital after working 41 years for the NHS into private practice. So I've seen very different side to fertility treatments and investigations. And again, I'm of the opinion that women or couples who've got the money to pay, it affords them an element of choice, but it's still important that it's fully informed consent, whether it's privately funded or government funded. And I think that's the point. And I was really pleased that Youssef had brought up the point about patients may not have any embryos to transfer. The number of patients that I have seen for monitoring that have consented to PGTA that do not know they may have no embryos to transfer, and that's hugely important. So again, fully informed consent. I can't express that strongly enough. So I was really glad that Youssef brought that in.
Oh, thank you so much. No, I agree with you. I think all of us here are signed up for this to do the best what we can for our patients, and it's very important. You know, same as what you said, Valerie, is the way people market things, right? And they were like, oh, you definitely need PGT. You don't need PGT for everything that you do. Like, you may want to pursue it, again, privately versus NHS is different. for various other reasons, as selection or whatever. But again, from what Joyce is saying right now, there's been evidence for years now that says it doesn't work. But the issue that we have is there's always a counter argument for these things. People always find a counter argument. Oh, this paper was not done well. This analysis was not done well. You did a subgroup of analysis of the different age bracket. It was not an intention to treat. There's a counter argument to this. And I think where we are all getting tired in a way is like we're having the same argument, like you said, for 30 years. And hopefully where we come in is if we can all agree that we just potentially need this, well, we're coming towards the end of the argument now. If we have something that's a trial that's well designed in the age bracket specifically, we'll look about the randomization structure, and that closes the chapter of this, because otherwise you're still having this continuous argument about previous study. I'm currently doing a paper right now, just looking up the amount of systematic reviews on PGT, and you realize that all of them are mixed. Blastocyst, cleavage, they're all coming to one. All right, so you have the evidence itself out there is not great. So you're looking at systematic reviews being quoted for a number of papers referencing the systematic reviews, whether it's in network meta-analysis or whatever, and they're all put in the same bracket. But now when you start differentiating the platform that you use, you realize it's actually not that good. And this comes down to the whole concept of how do you grade an evidence? How do you believe what's published out there? Is it actually high integrity research that's out there? And I completely agree with Joyce in saying that this argument has been gone for years now, but it's about selecting which part of the argument we can actually refine, and so that we have a definitive answer in order to say once and for all, it actually is not worth it for anything. Just rely on morphology. It's cost effective as it is. You don't need to pay an extra £500 per embryo for the sake of it, because you may not have anything to transfer anyway.
So along these lines, Yusuf, I want to ask you if you could explain a little bit more about the pilot study in terms of number of patients, because there's a question here by one of the attendees, and she's saying that, as you mentioned, we are not improving the embryo. We are just having, an analysis to see if the embryo is euploid, aneuploid, or has mosaicism. So then you show that cumulatively, when you have more euploid embryos, then you get this, advantage of actually offering PGTA, which is a challenge for us, because obviously to get more embryos in a patient over 35 years old is challenging because of the ovarian reserve. And so how could we, in terms of translating your pilot data into clinical practice, so shall we get, protocol to get more eggs in terms of repeating the stimulation? There are some protocols like the Duistine for patients at advanced age, or, could you elaborate a little bit more on your study, design and results?
Yeah, of course. So we got two things. Is when we looked at this was a pilot study looking at feasibility. So looking at whether it's actually possible to start with. Caveat is we did this during COVID. So this extended the length of time from a recruitment point of view. The sample size was put as 100. And we recruited around 247 in that study during that time frame. And 100 were randomized. 138 were eligible to be randomized, out of which only 100 were eligible to go through. And the reason this 38 did not make it to randomization, they were the right age bracket, but one of our criteria for randomization was at least 3 embryos to be of good quality for biopsy. And we were going to biopsy and grade all of them, compared to, for example, the Yan paper, which only selected the top 3, morphology versus top 3. We decided to do all of it. And 100 people were randomized into 50 in each arm. And then we presented there was no difference in clinical pregnancy at first transfer, live birth rate, or miscarriage rates at all. The number of eggs collected were the same in each. So they were all balanced. It was all accounted for. Average age for our study completely was 38 as the average age for the patients that we recruited. And but for the patients who had 3 euploid or more than 3, for example, when you transfer more euploid, chances are you'll get pregnant faster. That's the whole premise of it. So it doesn't increase the cumulative live birth rate as a whole. We did it up to 3 transfers. So not like, if you transfer all 7 embryos that you have, you'll get the same cumulative live birth rate, but just within a year bracket, for people who failed the first transfer, if you transfer up to 3, the chances of a conception the time to a conception was shortened. Now, the issue that we had is, what about these 38 patients who did not make it to randomization? Those are the patients who would not be part of any trial because they're not making it to randomization stage. They were above 38, where the average was 39. They only had an average of 2 embryos, so they did not make it to randomization. Now, if you look at the time to live birth for them, probably it doesn't matter because they only have 2 embryos. So you transfer one after the other, the time to live birth concept doesn't matter as such if you're just having minimal number of embryos available. The time to live birth comes into play if you have a large proportion of embryos. So from a clinical point of view, what we've adopted at the moment is a 3 cutoff. So if you have 3 embryos and you want to consider having embryo screening on them, you can. Bearing in mind, we've talked about the fact that the live birth rate, etc., you will get pregnant anyways, but just a question about whether you get pregnant a little bit faster through EUPLOD transfer than a morphology-based transfer. So that's where our cutoff is. From a practical point of view, we're looking at, if you got 3 and above, consider PGT. If you want it, if you have the risk factors for it, but less 1 or 2, don't consider it. Just go ahead and transfer, because there's risk associated with the biopsy, with the freezing, the thawing, and that could be at your detriment. So don't bother about it. Also from a cost point of view as well.
Yeah, and one quick question about the transfer itself. Was that in this study, was that artificial endometrial preparation? Was it during the natural cycle?
We had mixed. Yeah. It was not regimented. It had to be medicated. In our center, 60% are natural modified FET. So unless someone had a reason for a medicated like PCO or whatever, we'll give it. Otherwise, it was completely mixed. And the one who had the FET reflected our clinical 60-40% mix of natural modified versus medicated.
So do you think there's any difference actually, natural versus artificial? Because there's a lot of discussion now about the best protocol for frozen embryo transfer. Now, particularly for embryos that had been biopsied and then analyzed, do you think there's any rationale for stressing the natural cycle? Or
personally, no. No, I think you're looking at endometrial lining preparation. At this point, if there's an indication for a medicated, you'll have it. But this is not what's going to improve you. Like medicated is not going to make you higher likelihood of a pregnancy. And patients prefer the natural in a way because of the advantage of the less number of medication required. And the outcomes, and again, from a validation point of view, we've had similar outcomes, whether it's EUPLOD morphology based or natural versus medicated completely. But the one thing that, just to end here, is when you're designing trial, as is what we're going to be doing for ours, is each outcome has a different sample size. So you can't just have one sample size for 3 outcomes. And what we've figured out that, for example, if you're assessing miscarriage as such, as a reduction strategy, sample size is much bigger. You're looking around 2,000 for an 80%, 10%, 80% power. Well, if you're looking at clinical pregnancy for first transfer, you're looking at only 400. And that's, again, a limitation that we have when we're designing. Where do we draw the line in terms of finding a sample size that would assess all 3 outcomes? Or do we actually have the caveat that this sample size may not be enough to actually assess miscarriage reduction as such? Because for the confidence interval that we had with our pilot, we need much, much bigger sample size for it to be relevant.
Yeah. Well, thank you very much. Valerie, Joyce, and also Yusuf for participating in this first session. Now we are going to have session number 2 of our webinar, and I will handle the session to Valerie for her to introduce Professor Harper, and then we continue until the second lecture that we'll have during this session by Dr. Viana, and then we have again our Q&A. So please stay with us during session 2 and post your questions in the Q&A.
Thank you, Sandro. Well, I think, Joyce, you must have cut your bio in half because I'm sure this doesn't do you justice. But anyway, I am delighted to introduce Joyce Harper, who is an internationally renowned educator, author, scientist, and an excellent public speaker. She is Professor of Reproductive Science and Head of the Reproductive Science and Society Group at the University College in London's Institute for Women's Health. With over 35 years of experience in fertility, genetics, and reproductive health, Joyce has published more than 240 scientific papers and 3 books. Her work focuses on women's health, fertility, menopause, and reproductive education. Joyce co-leads InTune, the UK Menopause Education and Support Programme, and co-founded both the UK Fertility Education Initiative, which is an amazing resource. And for anybody that hasn't been onto the British Fertility Society website, I would advise that you do that. There's excellent animations that really just enhance and raise awareness of reproductive health in the younger generation. It's really, really good. And also the International Reproductive Health Education Collaboration. Joyce is also founding member of SwimHer, researching women's health and cold water swimming. That's something I didn't know, Joyce, so that's something new to add to your bow. And as an ambassador for well-being of women and Pads on a Roll, Joyce is passionate about improving education and support for menstrual and reproductive health worldwide. So I am delighted to invite Joyce to give the next talk, and this is on managing patient expectations with regards to treatment add-ons. Thank you, Joyce.
Thank you, Valerie. That was still too long. It's a real pleasure for me to give this talk because I have been a patient. So I had wanted to have children at age 30. My partner wasn't ready. So I know what that feels like for the many women where they're in that situation. I think that's a growing issue as well. And then I met someone at 35, first date, said, I want to have kids. We tried and tried and tried, a menstrual period, another period, another period. So it took me 7 years to have my children. I delivered my first son just before my 40th birthday, and then I had twins from frozen embryo transfer at 42. So I have been both sides of the table. So I am very, very passionate that we educate the patients and the public with correct information. And Valerie touched on this. We are now bombarded with social media and with misinformation. And the patients come to the clinic now absolutely brainwashed with misinformation. There's not a day goes past where we're not talking about this. And there's lots of people trying to rectify this. Actually, the menopause field is equally as bad as the fertility field. They're both really, really inundated with misinformation. And unfortunately, some of the misinformation coming from health professionals themselves. If they're selling something or selling a supplement or a treatment, as we will see, and we've already seen, add-ons are expensive treatments. They, as far as I'm aware, none of them are offered on the health system in the UK or in other countries. So patients are paying for these. But I've been that vulnerable patient. I've been that patient. I did acupuncture. I did reflexology. I didn't take any supplements. I went and looked into them and just it was over the line for me. But I'm someone that's worked in this field for almost 40 years. So I feel very, very passionate that we are not doing justice for our patients at all. So I'm going to go through that in this talk. So I am on social media. I do try, but I'm going to tell you some examples from where I've literally been abused, really abused. One of them just now, which I'm going to tell you about, with patients telling me that I'm wrong. And a common phrase that I write on the end of my comments now on social media is, what do I know? I'm a professor with almost 40 years experience. I'm not selling anything, but what do I know? But it's not their fault. It's because they are absolutely sold with brilliant marketing, absolutely brilliant marketing. So I'm going to come into that right now. Good. The slides are working. So just some disclosure. I do get paid by a number of companies to attend conferences and give talks, but none of that will have any influence over what I'm going to say today. I will be saying my opinion, and I always make that caveat at the beginning. This is my opinion. So, oops, sorry, gone too far. Oh, we'll have to go back now. Don't know. I should be able to go back. Can we go back? Yeah, what I'm going to talk about today. Now, you've already heard quite a lot about add-ons. One thing I've heard many people say is that the definition of an add-on is controversial. I don't think it's controversial at all. So I'm going to tell you my view and then some HFEA information about patients' expectations. Now, I was very lucky. I was part of the HFEA committee called the SCAC committee, and we were the ones that developed the first traffic light system. So I was in there right from the beginning, and you'll see why. And I was also one of the team in ESHRA that wrote the recommendations. And as I said, I'm very interested in marketing. So I'm going to look at how clinics market this. But my question will be, will anyone listen? And I think PGTA is a classic symptom of this. In my view, sorry, Yusuf, but in my view, I don't think we need another study. We've got 30 years of studies. It doesn't work, but nobody listens. And unfortunately, we have a growing number of clinics in the US. There are clinics that do PGTA on every single patient. And I have heard that there are a number of clinics in the UK that do PGTA on almost every single patient. So will anyone listen? No. And I think the problem is money. I think that we do have a huge amount of money wrapped up in IVF around the world. It is a money-making scheme. And having been a patient and almost not going through it because I couldn't afford to go through it, I have a comment. Should we be making money or making families? And I think we've lost our way and we've become a little bit blinded by money. And I'm going to finish off just talking about some new add-ons and AI. So my view of what an add-on is any technique that is a variational add-on from the routine IVF cycle. And this accounts for almost all of the add-ons. So we've been doing routine IVF and ICSI for decades. Now, as I've said, in the US, they've made it routine. PGTA is routine, so that doesn't even quite fit my definition. But it's something that's not essential. You don't need this to go through. So for example, if you've got good sperm, you don't need to do ICSI to go through your IVF. But some people will add that on. They'll say, no, we need to do ICSI. You don't need, Yusuf said, you don't need PGTA to go through your IVF, but it does include laboratory, clinical and complementary treatment. So it is a little bit wider than that. And it also includes some diagnostic techniques, which you might do before you actually come through for your cycle. And in my view, we need to know that these techniques will improve the live birth rate. We've already heard that from the other speakers. So from the patient's expectations, this is from the HFEA website. They've said patients want accurate, up-to-date information about treatment add-ons. They also want to be given safe and effective treatments at a reasonable price. They are open to new treatments and to trying out untested ones, as Valerie said, but want to understand their limitations. A worrying development is that they seem to be losing faith in the sector, feeling that they are sometimes being ripped off. And I totally agree with that. So this is the patient survey. The HFEA every few years does a patient survey. It's a very confusing graph, but the yellow bar is 2018 and the green bar is 2021. And the top one says none of the above. So it means that basically in 2021, less patients had add-ons than in 2018. So sorry, that's a bit complicated. But the top ones there, we've got things like acupuncture, time lapse, PGTA actually in the UK has always been quite low for various reasons. And also just to say that my colleagues in Australia really have the same issues that we have, and they've been doing a lot of the similar work that I and others have been doing. And they've done a survey as well, and they found that 82% of women had used an add-on, and the most common was acupuncture, PGTA, and Chinese herbal medicine. And they found that 66% of patients had some regret, and 83% had regret if they didn't get pregnant. And that's probably because of the expense and the money that they've spent having this treatment. So I'm an evidence-based scientist. I want us to practice evidence-based medicine. So the trouble in today's society, it's so unfashionable. This is a pyramid of evidence-based medicine. At the top, we have the randomized control trial, which you've already heard about, how that works. You've got a treatment group and a control group, and the patients are randomized into that. And then when people have done quite a few of those, people take that data and they torture it a little bit, and they do a systematic review, and you will see systematic reviews with the same data that came to different conclusions. So that can be very complicated. But what we see a lot of people talk about are things like case control studies, observational studies, cohort studies, and they start extrapolating that and making it sound like it's truth and that is evidence-based medicine, and it's not. So I tell everybody, do not believe every paper that's been published. And there is this misinterpretation, even by health professionals. And we've seen this with these add-ons. We fake it till we make it. We give the impression that this is going to help our IVF patient. And unfortunately, that's not, well, you'll see with the add-ons, there's none of them have, well, one of them has evidence that it will improve live birth rate. And it's been such a hothouse of arguments and discussion for over 30 years. And these two people here, Paolo and Elizabeth Holmes, they are both people that faked it in the health sphere. They had that. Paolo said he had a trachea, an artificial trachea from stem cells that could help people that needed one. And Elizabeth Holmes said she had a kit that could measure lots of diseases that you could do at home and just on a finger prick test. Neither of them were true. And both of them ended up in prison. So I actually, when I give this talk, I say to my colleagues working in PGT, oh, sorry, not just PGT, so I've got PGT on the brain, working in add-ons, working in an IVF clinic, be careful. And I'm going to mention this right now, but there is a huge lawsuit in the USA against PGTA. And the last time I looked, there were 700 patients that apparently are suing. They've gone at the moment for the companies that are making the test. But I've been told that the companies making the test have turned around and said, don't sue us, sue the IVF clinic. We just made the test. We didn't sell you the test. It was the IVF clinic that sold you the test. So you can all go and Google that, or I can put it in the chat later. But there is a big lawsuit against PGTA because, as you've heard Youssef say, ESHRA, the HFEA, the ASRM, and now NICE are saying it doesn't work. And so patients are saying, the clinic told us this worked and it's going to improve live birth rate. It even says it on their website, but that's not what 4 now established societies are saying. So I really give a note to people when I'm at a conference that be careful of what you're telling your patients these add-ons will actually achieve. So these are just the publications that I've done around PGTA, and the main one for me is the ESHRA, because we looked at so many add-ons, and I'm just going to take us very quickly through that. And for me, I've worked in PGTA. I don't work in PGT now, actually, and I've never done PGTA, but I worked in PGT since 1992, worked in IVF since 1987. And it all started for me with the whole story of the PGTA. And then this paper in the top left that we did when time-lapse first came in. This is what stimulated this paper about when and how should we bring new technology into the IVF lab, because I was just seeing the explosion. And we wrote that paper more than 10 years ago. Will anyone listen? No one's listening. Too much money involved, really too much money. So we've heard a little bit about this morning. This is the first version of the HFEA traffic lights, which I was involved with. And you've already heard we had red, amber and green. And PGTA had 2 reds because there was the cleavage biopsy and the blastocyst biopsy. And we've heard endometrial scratching, amber, and all other things there. And for the HFEA, they've rated these on whether they improve your chance of having a baby. And Julia Chain, the chair of the HFEA, said there is currently no conclusive evidence that any of the add-ons increase your chance of a pregnancy or a live birth. So after I left the committee, I'd been on there for many, many years, the HFEA made this new version, and now red is much, much more concerning. We had tried to do this, so I'm really glad that they did it. Now Red actually says there's a safety concern, not just that it's not going to improve your chance of getting pregnant, there's actually a safety concern. So sorry, this isn't very pretty, this one, but this is from their website. So we have endometrial receptivity testing, we've already heard. We've already heard about the immunological tests, and there's a couple of them that are red, and the other red is PGTA. So in my view, we're done. We shouldn't be even talking about it anymore, but it's not going to happen. So this is my ESHRE group that we did lots of work with. It was really great to talk to. And the HFEA, when we were doing this work, had only worked on 13 add-ons for various reasons. We worked on 42. And this is all freely available online if anyone wants to go and read the paper. And just to go quickly through how we did this, we discussed many, many ways of how we make this clear. So we call things recommended. They can be considered, currently not recommended for routine use, and not recommended at all. So I've just tabulated the results. Screening hysteroscopy can be considered. Then we've written about laboratory techniques that artificial oocyte activation and artificial sperm activation can be recommended in very, very specific circumstances, and microfluidics can be considered. Then we had the hyaluronic acid was recommended. That was the only one. And I can tell you that when we were originally developing the traffic light system with the HFEA, there was a discussion about making the hyaluronic acid green. And I won't go into the politics of that, but there were politics around that. And it was then rated amber, and it still is, as far as I'm aware. And on the clinical management, none of them were recommended at all. So going to the patient perspective, the patients are listening to what's on clinic websites and in the media and what they read about. It's all about marketing. Now, if you're an IVF clinic and you just say that you do total evidence-based, you only do procedures that are validated, you have a very empty website. You have a website that doesn't look very sexy at all. It's just got about IVF, ICSI, and freezing. If you put that you're doing all of these sexy add-ons and you're developing all of this technology, it's a brilliant marketing place to be, obviously. So these are quite old. These are old ones that we've looked at. These are a couple of papers that we did. We did one looking at assisted hatching, PGTA, and time lapse. Clinic claims improve success, improve outcome, etc. That's quite an old paper now. And we looked at the costs. The costs are a lot more now. And then we also looked at complementary therapies. They're not graded by the HFEA, but if they were, I would grade acupuncture yellow and reflexology red. And then I always want us to have solutions. So the HFEA they worked with the Competitions Marketing Authority. And when I was young, if you had an advert for something, it had to be real. It couldn't just have made up things on it. And now that seems to have gone. You can say what you want in your advert for your fertility supplement or your add-on, and it's fine, even if it's not true. And as I said, in Australia, VARTA have also been doing a lot of work on this. But all of this work that's been done, the Competitions Marketing Authority wrote a great report. And they said they were going to do things. They were going to take people to court if the websites had the wrong information. But nothing has happened. Nothing. So in conclusion, are we making families or making money? The UK fertility market is worth millions, and globally, that's going to be even more. If you want to see a recent comment by me, there was an article in the Sunday Times just gone in the UK. I think it's available online, where a patient had a stroke after some treatment, and there was a discussion about after she had an add-on treatment. And I said my view, and I've said exactly what I said here about clinics want to make their websites look great. It's a difficult thing. I can absolutely appreciate that. But I think we've got to be really, really careful. And now we've got new add-ons because it's so great to have all this new technology. We all love technology. So AI is appearing and automation. So we've got time lapse. There's no evidence that time lapse is going to improve live birth rate. But now we're talking about, using AI. And we've just done this study where we looked at UK IVF clinic websites. This first bar is the most important. It's of all the clinics that were talking about time lapse on their website, and over half, exactly half of them are talking about AI, how they're going to use AI to help choose the best embryo. It's brilliant marketing. It's fantastic. But that is not what we want for our patients. So are we empowering our patients or are we exploiting them? We've got all these new things bubbling under. I do a podcast. I've had some brilliant fertility people on there, and I've talked about artificial wombs. We've talked about empowering women. And I want to just finish by talking about what I had a problem with on social media in the last few days, and that's McDonald's fries. Because apparently lots of IVF patients have got it into their head that by eating McDonald's fries on the day they have their transfer, they're going to improve their chance of getting pregnant and reduce ovarian hyperstimulation. That is not true. And I put that out on a reel on Saturday, and I have got bombarded by insults and the most disgusting comments by people who wrote swear words coming out of my mouth. So there's people like us trying to give the right information, and it's just so hard. So just thank all of my team that I work with. And if you want to see what controversial things I talk about, I am on social media. Thank you.
Thank you very much, Joyce, for this very thought-provoking talk. I think everyone will be very, willing to see the recordings of this webinar later on. I'm sure this is excellent. So working in this field for 25 years, and we are very reluctant to introduce some of these add-ons in the clinic. So I feel more relaxed at this point. Well, now it's my great pleasure to, introduce Dr. Marina Viana. Marina is a reproductive urologist with a special focus on andrology. She earned her medical degree in Brazil, completed her residence training in the University of Campinas in general urology, in general surgery and urology. And she then specialized in male infertility under my mentorship. And then also she went on to complete a fellowship in reproductive medicine at the Federal University of São Paulo. And since 2023, Marina has been a full-time consultant in male reproductive health at our center, Androfert, in Campinas, Brazil. So welcome, Marina. And Marina is going to speak about the impact of the supplements and the impact of the global fertility supplement market, given an overview about that. Welcome, Marina. The floor is yours.
Thank you very much, Professor. It's a great honor to be here among all of those experts. So today we are talking about the global fertility supplement market. Let me see if I can pass my slides. Okay. So fertility supplements are a multi-billion-dollar market. And when I say $1 billion, I mean that is estimated to grow about $3.052 billion by 2030. And it's growing about 7 to 8% per year. That's an industry mainly dominated by North America that has about 35 to 44% of global revenue in 2023, 2024, but Asia Pacific is growing very fast in this market. Nowadays, we have a female-focused product that is currently dominated with about 52 to 55% of sales, but men's products are fastest growing segment. And by that, I mean that roughly half of the global fertility supplement spent is now on men product, with about 1.1 billion and growing at 8% per year. And this growth is mostly driven by rise in male infertility issues, greater awareness of male factor, and of course, the e-commerce and subscription-based sperm health packs. Globally, over half of infertile patients use some form of complementary and alternative medicine that we call CAM, and around 1 in 3 infertile men report CAM use without our knowledge, and I think that may be a problem. Here I have a little table of supplements and fertility that we use for men and women, and as we can see, the certainty of evidence is low or very low among all of them. And you can see that L-carnitine, coenzyme Q10, antioxidant, and selenium and omega-3 fatties have a modest improvement in motility, morphology, and semen quality for male. And when we talk about women, we see coenzyme Q10 and antioxidant omega-3 improving ovarian reserve, making a higher fecundability, but none of them has proven to be or to have a greater impact in live birth rates. Myoinositol, N-acetylcysteine, and melatonin is it's good for increasing clinical pregnancy in a selected group of females, such as PCOS. Vitamin D has no consistent benefit except in those with deficiency, and multivitamins and folic acids are recommended for neural tube defects prevention, but has no robust benefit for fertility. We're going to dive a little bit deeper in the male factor supplement industry. And here you can see that men's market are growing in a very high speed. And many male fertility supplements claim to improve fertility, but their products are rarely backed by evidence and their efficacy remains unproven. And by that, I mean that this paper evaluated top 17 US male fertility supplements sold online, and they find out that only 22% of ingredients had any published evidence on improving semen parameters, and only 17% had data showing a positive effect. That's a little bit scary in my opinion. And when we look to the supplement composition, we can see their compounds are antioxidant, micronutrients, energy supports, amino acids, and botanicals. Here we have a table with all those compounds and the impact on fertility. And as we can see, we have some level A evidence, such as with ashwagandha, coenzyme Q10, folic acid, improving sperm density, motility, morphology, protamine content. But we have a problem because when we look to high quality evidence, we can obtain that through RCTs. And we have very few RCTs proving that. We have many marketing claims. And when we look to those supplements, we can see many typical components in all of them, like micronutrients, such as zinc, selenium, folate, vitamins. We have some mitochondrial support with L-carnitine, some anti-inflammatories such as omega-3, some other amino acids, and botanicals, maca, ashwagandha, tribulus. Here in Brazil, the use of tribulus is very common, and we don't really know if that's a problem or not. And we also have a regulatory nuance. In the European Union, for example, under current EFSA health claim rules, selenium is the only supplement on the very few nutrients allowed to make a formal fertility statement, like selenium contributes to normal spermatogenesis. But many other bold marketing claims about sperm count, motility, DNA fragmentation that go well beyond what regulators actually permit, and that's another problem. Diving a little bit deeper in the oxidative stress and male infertility, why antioxidant supplementation makes sense. We know that oxidative stress is responsible for it's responsible or involved in 25 to 87% of male subfertility cases, and that the excess of reactive oxygen species can damage sperm membranes, can alter motility, and can alter DNA fragmentation, leading to embryo development issues, implantation failure, and miscarriage. Oxidative stress is also linked to modifiable lifestyle exposure, such as smoking, diet, toxin, and heat exposure. So the rationale of using antioxidants and lifestyles are a biological attractive path to counteract those excess of ROS. But how do we measure oxidative stress in males? We have 3 types of tests we can perform. The first one is the sperm DNA fragmentation index. Can be assayed with SCD, SCSA, Tunnel, Comet. So it's widely used, but we have those different platforms with different cutoff. So it's very important that when we are following a patient, we always follow in the same platform. Okay, that's very important. It can measure indirect oxidative stress. The other test we can do, it's the oxidation reduction potential. It's like the oxidant stress number, but the problem is we can't correlate the ORP with the SDF. So are we measuring different aspects of that damage? And last but not least, direct ROS assays by chemiluminescence, but the use is very low in real data clinics. Well, does it work? Because we have a huge commercial market versus a very weak evidence for heart outcomes. And that is a Cochrane review of antioxidant for male subfertility. I think it's the biggest one involving this, this team. And the headline findings shows that antioxidant may increase chances of live birth and clinical pregnancies when compared to placebo or no treatment. But most trials were very small with a high risk of bias and very heterogeneous. And when analysis is restricted to low risk of bias study, the apparent benefit on live birth disappears. So the certainty of evidence was rated as low. And after that, we saw the MOXIE trial, a contemporary RCT data with 2 arms, one of intervention with a daily combo of antioxidant, and the other one, the placebo. The study was conducted to 3 to 6 months, and the primary outcome was live birth by 6 months. But the key results showed no significant improvement in sperm morphology, motility, or DFI at 3 months between antioxidant versus placebo. And the cumulative live birth at 6 months was something very strange, 15% in the antioxidant group versus 24% in the placebo group. The thing is, MOXIE trial has some main criticism because the trial was actually stopped early because an internal pilot study that shows no benefit of antioxidant on semen parameters and DNA fragmentation, which were intermediate endpoint. And as a result, the study did not recruit enough participants to be statistically relevant to evaluate the primary endpoint that was live birth rate. So critics argue that the author's conclusion about the live birth rate are therefore limited by sample size and not definitive. Another important thing is that patients were included based on general abnormal semen parameters, such as low count, morphology, high DNA fragmentation, rather than a confirmed diagnosis of oxidative stress. And only men with elevated levels of OS should have been included because those with normal or low oxidative stress might not benefit or could even be harmed by the excess of antioxidant, leading to a reductive stress. That being said, the overuse or inappropriate dosage of antioxidant can disrupt that delicate balance between antioxidant and oxidant, which can potentially cause reductive stress that is very detrimental to sperm function as oxidative stress. So some argue that the formulation or dosage chosen in the MOXIe trial may have contributed to this effect in some men. And when we look to the compound used in MOXIe, they used a commercially available combination of multiple antioxidants, which assumes that there are no interacting or potentially opposing effects between different components. And the study design did not allow for the differentiation, of the effects of individual antioxidants, because we know that coenzyme Q10 has shown promise in other studies. And there was no established method used to quantify the baseline oxidative stress that was very problematic in MOXIe trial. So we couldn't follow the status of individual patients before or during the treatment, which made it difficult to determine which patient might actually benefit from supplementation. And last but not least, in the placebo group, there was a funny result because all 4 subgroups of semen abnormalities, low count, motility, morphology, and high DNA fragmentation showed a statistically significant improvement at the 3-month mark, a finding that raised question about the methodology and was not fully explained by the authors. So MOXIe has those problems. Sorry, that was a trial conducted, a prospective study conducted by Dr. Peter and Dr. Sandro, where they evaluated men with high DFI, and they used 3 months of personalized lifestyle program and oral antioxidant regime. And what they found was that DFI dropped from a median of 25, almost 26% to 18% after 3 months. But there was no statistically significant ORP reduction, and that corroborates with that I said before, because there's no correlation between DFI and SRP. Again, are we measuring different types of damage? When we talk about guidelines, the European guidelines advise against routine antioxidant therapy for idiopathic male infertility, citing conflicting evidence and low quality data. And they use, if any, should be selective and ideally within research or after a proper evaluation of oxidative stress. When we look to safety, here I have, sorry, somebody said something. I heard something. Okay, sorry. So here I have a systematic review that talks about toxicity of antioxidant supplements in the male factor infertility. And they concluded that RCTs rarely reported serious adverse events, but many did not systematically assess or report safety. And there is a theoretical risk on reductive stress and disruption of physiological redox signaling with high dose or multi-antioxidant regimens. And we cannot assume that more antioxidants are harmless, especially in high doses, long-term, or in men without documented oxidative stress. So why is that even a problem? What is reductive stress? That's a state where the cell's reducing capacity is disproportionately elevated, and that will create an imbalance by excess of reducing equivalent like NAG, NAGP, and glutathione. And that can be very harmful and potentially caused by taking too many antioxidants, especially over longer period of time, which can deplete ROS and disrupt normal cell function. Dr. Aitken has been talking about it for a long time now, and the thing is, indiscriminate antioxidant therapy can drive a healthy man into reductive stress, and the only way to prevent that is to use diagnostic redox assays and monitor longitudinally, calibrate dose, duration to restore that physiological balance. But what are we really prescribing in the real world? That's a global survey among reproductive specialists, and many clinicians do prescribe antioxidants in male infertility, but the practice is highly variable and there is no consensus among which formulation, what dosage, how long to treat, and which patients can truly benefit. And that highlights the contrast between the enthusiastic adoption in practice versus the cautious or even the negative guideline recommendations. In the real world, what should we say to our couples? I think the best message is we can try a target antioxidant and lifestyle plan if we document high oxidative stress markers like DFI, but we should reassess in 3 months and stop if there's no biological gain, because over supplementation can backfire. And here is my suggested practical algorithm to test, target, time, and track. We should test with a full andrological workup with history, physical examination, semen analysis, and hormonal panel. And if we have recurrent RT failure or idiopathic and unexplained male infertility, we should add DFI. We should also target lifestyle optimization, treat fixable causes such as varicocele infections, and we should consider a defined antioxidant regimen only if DFI or other oxidative stress marker are clearly elevated, or in couple that already failed IVF or ICSI. Always remember to reevaluate those patients after one spermatogenic cycle, about 3 months after you start your intervention. And we should track, we should repeat DFI. And if DFI meaningfully drops, IRT using ejaculated sperm is indicated, but if not, we should seriously consider using testicular sperm. Another important thing is to remember to stop antioxidant if labs normalize or if there's no benefit to avoid reductive stress. So key points, that's a very multi-billion market and it's growing very fast, dominated by North America, but Asia Pacific is right behind. We should always remember that more than half of our patients worldwide is using CAM, so it's very important we look to that. And in that detail audit I showed you, we saw that only 22% of those ingredients had any RCT evidence. The biggest review in literature tells us that antioxidant may help, but the benefit disappears in high quality studies. The European guideline discourage routine antioxidant use, especially in idiopathic male infertility. And we have to remember we have that problem with the regulatory evidence, because commercial messaging is often stretched by those in the market. To finalize, my take-home message is that oxidative stress damage and SDF can lead to failed fertilization, poor embryos, miscarriage, and implantation failure, and that antioxidant may increase pregnancy and live birth odds, but we have to remember that we are talking about older, small trials and high bias study. And when we look to MOXIe, it was shown no improvement in semen parameters, pregnancy, or live birth, but we have all those things involving MOXIe trial. That being said, a focused, personalized approach with lifestyle and antioxidant mix in men with objectively high DFI or OS marker and failed ART cycles can improve DFI, but we don't have RCT level proof that this DFI drop will lead to increased live birth. So we really need that trial for the right dosage, regimen, and time of treatment. Thank you very much.
Thank you very much, Marina. This was very comprehensive. Thanks a lot for covering, the male side so well, and also highlighting some of the perhaps overuse of supplements in female patients as well. I would like to open this session for questions, and would like to invite Professor Harper, also Valerie, Yusuf to join us and discuss. And I would like to start with question from one of our attendees. I think this is for you, Joyce. And here is the thing not related, it's related to PGTA, but it's related not particularly with live birth, but the concern about having a baby with a major congenital anomaly. And this is, this is something we see. The patients come in and say, okay, you explain that the evidence about PGTA is not robust, but how about the risk of me as a 38 lady having a baby with congenital anomaly, and if I don't do it and I have it, I won't be able to, stop the pregnancy. And then if the doctor is not explaining that there is a test that could actually, overcome that situation, is that possible even for litigation, things like that? So we want to hear your thoughts on that.
Yeah, and I have this question many times. So PGTA is not giving you a genetically normal embryo. All PGTA is doing is looking at the chromosomes and looking at the number of chromosomes. So the congenital abnormalities can happen for a number of reasons. What PGTA can do is check for that. Well, there's 3 chromosomes that we need to worry about. Obviously, chromosome 21, and not worry about, but be concerned. So chromosome 21 is the only chromosome that if you have an extra copy, it can go to a live birth and you'll have a Down syndrome child. Chromosome 13 and 18 can also be sometimes in extra copy. They can go quite far. They can sometimes have a birth, but that they will not normally live long. So the only thing that the PGTA could prevent is an issue with one of those chromosomes. Any of the other chromosomes that are aneuploid, they will not last very long. They may have a miscarriage, and there's discussions about whether PGTA reduces miscarriage. My analysis of the data is that it's on the fence at the moment. I'm not really convinced that it does do that. And if you really look at the data, so it's not going to reduce the risk. It will reduce the risk of a 21, 13, or 18 pregnancy and maybe birth, but nothing else. And then we do have in almost every country, I know termination is not possible in all countries, but in every country, we do have very robust tests for when a woman is pregnant to check for the abnormalities of those 3 chromosomes. So there's brilliant ultrasound, there's brilliant non-invasive testing, so we can know that. So I do not think that's a valid argument. If a woman is concerned about that can actually, I'm not saying don't do PGTA at all. I think there are patients that come with concerns like that, or if they've had a number of miscarriages already. We don't have evidence, as Valerie said. We have to give them the information. But if they then chose to go and do it, that's absolutely fine. But on the clinic websites, it says it's going to improve your chance of having a baby or improve your outcome. Yeah. And that's not, we don't have any evidence for that.
Yeah. Thank you very much, Joyce. Now, Youssef, I want to, from your side, your thoughts on this, but also I want to add something else in terms of this sex chromosomes. I mean, we see patients here, a lot of male factor infertility, and we do a lot of, sperm retrieval for patients with azoospermia, including patients with Klinefelter syndrome, in which they are concerned that they could transmit the problem to the baby. So sometimes they come and say, okay, I want PGTA. So working in this field for so many years now, and we know that in specifically patients with non-obstructive azoospermia, when we find testicular sperm, we would like to have the embryos untouched, because everything we do for this very fragile embryo could compromise, the chance of implantation. So sometimes it's very hard to discuss with a couple that, okay, do less and don't do more in terms of invasiveness. And this is one point that I face challenging many times with my patients. I want to hear from you how you approach this issue of, congenital abnormalities and also sex chromosome. Adding or, discussing in another direction what Professor Harper just said.
No, I think I actually agree with what Joyce is saying. This is not a replacement for any form of antenatal care. You can also, the way PGT works, you look at it from an embryo point of view, but you can have de novo mutations later, and you have congenital abnormalities that develops later on that has nothing to do with what PGT testing. If you're doing PGT for the context of I want to avoid a completely abnormal pregnancy, that is not the answer for you. You will need to do your antenatal screening. If we do PGT, there's no way I'm saying you don't need your antenatal screening, you don't need whatever, because that's also something that people go, oh, we do PGT now and all my scans will be normal. I will not have a delivery. I will not have a preterm delivery, whatever. You can still have a cardiac abnormality at 20 weeks. This is not me. And this is where, again, what Joyce is saying is about how you tell your patients, how you market it is coming under. And people say, I've had information, even within the Fetal Medicine Foundation, where patients go and say, actually, I did PGT here, so I don't need scanning anymore. We never said that. You still need it. In fact, you should have it, because we've not tested for half the stuff that we're doing over there. So we are just getting you potentially to first trimester, if you want to do it. Beyond that, it's a whole arena of stuff that can happen. So you need to definitely have it done. So don't take it as a replacement for any form of care that you're having. Now, if you, again, from what you're saying, Sandra, patients want embryo tested for whatever in order to improve the outcome, fine, you can have it, but you need to be counseled properly. And it comes down to these things where you shouldn't just be, what Joyce was saying is correct, like just listen to the most glamorous pamphlet and the most glamorous website that tells you, oh, we're going to replace everything, you're going to have a healthy baby boy without congenital abnormality. I do not know, and no one knows. So take it as you want it, massive pinch of salt with it. It may be benefit for you. It may be useful for you for your own personal reason. No, it's not a blanket cover for everyone that everyone's going to have it. If you want it, you're counseled about it, you know exactly what to do, go for it, you understand the limitations for it, but it's not a replacement for any form of care. And it's this is whole thing that goes on. People use it to just for money marketing as well, because it is great money.
Can I just add there as well? I think Youssef and Joyce's responses are a perfect example of patient information and managing patient expectations. And I think if patients were afforded that comprehensive explanation of what they are entering into, then I don't think we'd have a lot of the problems that we have now. And I think, as I say, that's managing patient expectation. And I think both of you have highlighted that just perfectly. So thank you.
Oh, thank you.
Yeah, thanks a lot for this very interesting discussion. There's a question here that is more into the male side of the equation. I think this is for you, Marina. So they're asking about any add-on treatment for patients with azoospermia. Is there anything that you have in your mind that could help, like the supplements that you have discussed? Do you think it might have any role in a patient with azoospermia? I think they are talking, mostly in non-obstructive azoospermia.
Well, I think non-obstructive azoospermia is one of the most challenging scenarios we have in male infertility. And it's very hard to say if supplements can help in those patients. We don't even have evidence in patients with sperm in the ejaculate. But what I can say is that in our practice in Andrefert and in your work, we've been studying a lot hormonal stimulation in those patients, because they usually present hypogonadism, and that could lead to better outcomes. I think hormonal modulation, but I don't think that's an add-on anymore. I think we already have some evidence of good outcomes.
I think, Professor Harper has her hands up.
Yeah, just to say, Marina, I was with Jackson Kirkman Brown on Friday at the conference, and he was giving a talk about male infertility. And he said that some of his male patients are taking 3 supplements and all of them, for example, have selenium in or zinc in. And he said they are absolutely overdosing on these compounds. And he's trying to tell them to come off the supplements. They're doing damage, and they won't listen. They just will not listen. This is the trouble about marketing and about social media. We are giving our patients this wrong information, and somehow they absolutely believe everything they hear from an influencer, not from us, from the influencer. And they think, yes, I've got to do this. And the female market, and the menopause supplement market, all of the supplement market in male and female health is, as you said, huge. And I find that so worrying that the patients won't listen to the health professional. It breaks my heart.
And the thing is, because everybody thinks that is absolutely harmless, and they don't really look to the other side. That's a problem.
I think that into that field, especially supplements in male patients, also female patients, I think the influencers, they're better communicators than we are. I think we need to improve our, communication skills. Perhaps this is one thing that we need to invest on, because we see these patients coming with, well, sometimes during the consultations, it takes 10, 15 minutes because they start the list of things that they are taking, and they feel great, etc., etc. So for the doctor, we say, well, but you are investing significant amount of money per month in these supplements, and it looks like you don't need it because there's no, evidence or signal that you have excessive oxidative stress. So I think this is one issue. And what Marina said about this reductive stress is that when you give too much of arguably a good thing, so supplements, vitamins. So if you don't need it, and there's no marker to say, okay, in your condition, and this is more not routine use, but for a specific population. And this is why in this field, we need the trial, because most of the antioxidant trials, they just bring the general population of patients coming to the clinic for IVF, IUI, or whatever. They don't test. They have the patient doing treatment because of infertility, and then we can argue about that. And then they go for antioxidants or supplements, etc. But if I don't understand what's the baseline oxidative stress of this population, and I give something that is supposed to counteract oxidative stress, it's like, makes no sense, because you are doing something for reestablishing the balance of the oxidative reductive, and then you give a product that could potentially help some people, but at the end of the day, the message is wrong, because it shows no benefit, but perhaps not for the whole population, but for specific groups. So this is, a thing that we need to continue into that field to, because this is not so expensive. And I believe if we go for the right population, provided we have the evidence, and then we can actually, eventually improve the quality of the male reproductive health of these patients. And the other thing I want you to comment is, there's a lot of things in terms of adding things on the IVF field specifically that increase the cost at the end of the day. And in several countries like ours and others, the patients need to pay out of their pockets. So when we add PGTA, we add scratching, we add supplements, we add now artificial intelligence for selecting the embryo. So it increased the cost not only 10%, but in many cases, like 50% of the original cost. And then when the patient fails, and then we need to propose another cycle. And so this is another challenge we see as clinicians. And along these lines, there's a question here that says, well, I had this patient of 36 years old. She got like PGTA, got pregnant. I assume it was with euploid embryo. And then there was a miscarriage at week 19. So no embryos left for frozen embryo transfer. So how we consult these patients? Valerie, could you jump on that first?
Sorry, could you just repeat that last bit? I never heard that last bit, Sandro.
The last part, so this patient, she got PGTA for IVF cycle. She's 36 and she was lucky to get implantation, but the pregnancy miscarried at week 19. Yeah. So now no embryos left and she wants some advice. So, going for PGTA again or against it, how would you approach a patient coming with this question for you?
Well, I think obviously we'd have to consider, obviously you've told me a female age, we'd have to consider how she responded, how many embryos she had, what was the potential of her actually reaching blastocyst stage embryos in a future pregnancy. But again, it comes down to managing patient expectation, and I think respecting our boundaries of fertility practice and those of our obstetric colleagues. I think, we talked about I think Joyce brought in non-invasive prenatal testing. So again, it's what are our boundaries of professional practice within fertility? Yes, she may be fortunate to conceive again, but we can't guarantee that she won't miscarry again. So again, I think it's working closely with our obstetric colleagues for support of these women and couples going forward, that work in fetal medicine, that can offer non-invasive prenatal testing, etc. But again, non-invasive prenatal testing will not predict those likely to miscarry. So there are no guarantees whatsoever. So I think it's really important that we don't give false hope. If a couple feels strong enough emotionally, psychologically and financially to pursue another cycle, then that's fine. But often you'll find that one person in the partnership wants to stop and the other one wants to keep going. And again, that becomes really problematic. But I think as long as we remain transparent, honest, and provide the best information, evidence-based information that we have, at the end of the day, it's patient choice as to whether they want to go ahead again, but there's absolutely no guarantees. So I hope that answered the question. Joyce maybe wants to add something.
Thanks a lot. Yeah. Yes, please, Joyce.
Yeah, Valerie, brilliant answer. I mean, just to add, the patients must be aware that looking at the chromosomes, well, miscarriage can happen for many, many reasons. Yes, a lot of miscarriages do have chromosome abnormalities, especially as a woman gets older. But it can many things can cause miscarriage. And as I said, PGTA, the studies that have been out there that have looked at miscarriage, they've normally looked at miscarriage as a secondary outcome, so it doesn't quite have the same power as if you're looking at live birth rate. But miscarriages still absolutely happen when people have had PGTA. It's not something that's going to eliminate miscarriage or even reduce it. As I said, I don't think the evidence shows that it does even reduce it. So we shouldn't be telling our patients that if you go through PGTA, you won't have a miscarriage. That would be real misinformation. So I hope no one would be saying that.
Yeah, thanks a lot for that. So I think we are getting close to our end of our webinar. So it was great actually to have all of you. Youssef had to leave earlier because he's having a busy clinic today. I know that. So we thank him very much for taking the time out and being here with us today. So I want you to conclude with final message about, Edzon. So I will start with Valerie, then Joyce, and then Marina, and then I will close the webinar after that.
So I was just going to add to remember to complete the post-session questionnaire, especially if you work in the UK and you have to complete revalidation, it will actually count towards a reflective practice piece. So again, I think it's hugely important that you look at your information before the webinar and the information gained during the webinar. So that was really all that I wanted to add, and just thank you for joining us today.
So I just like to add that I think it's a really complicated time for anyone going through fertility treatment. We are all bombarded, our patients are bombarded with information, some of it which is misinformation. And I appreciate why IVF units would advertise add-ons on their website. But I think we're, as I said in that first slide, from the HFEA's patient perspective, we've got to be really true to our patients. So I wish we weren't having patients that were so led by corporates anymore, but it's the way things are happening. So I just would like everyone to really put the patient as number one, and we will have to try and undo misinformation, unfortunately.
Thank you. Thank you very much, Joyce. Now, Marina, what do you have to say?
I think what I like to contribute is that when we talk about infertility, we should never forget to have a closer look to the male factor. We are talking about a couple, so we shouldn't only look to the female. That was what happened through the years. So we should always evaluate male factor with an andrological complete panel. Thank you very much for the amazing lectures today. It was very, very nice.
Yeah, I would like to thank our speakers today and all of you for taking the time out and be here with us today. I would like to give special thanks also to Medea, technical support team, Alessandro, Patty, and also Chloe Schilnas for making today's session possible. They worked very hard to deliver this, excellent educational activities. So we are very proud of them. So please be informed that you will receive an email with a survey link after the session. So it's important to complete it for receiving this CME credits. And I would like to ask you to stay online for a few minutes at the end of today's webinar to fill in the survey, that it's also important for us to measure the webinar's educational impact and to learn more on what we can, develop in future webinars. So be informed that the session recording will be available on Medea's website in about 1 week, and you will be notified by email once it's posted. So with that, thank you very much. Have a great weekend ahead.